You have been asked to see Dave in the neurology clinic. Dave has been referred by his internist, who thinks his patient is having symptoms of multiple sclerosis. Dave is a 25-year-old man who has experienced increasing urinary frequency and urgency over the past 2 months. Because his female partner was treated for a sexually transmitted disease, Dave also underwent treatment, but the symptoms did not resolve. Dave also recently had 2 brief episodes of eye fuzziness associated with diplopia and brightness. He has noticed ascending numbness and weakness of the right arm with an inability to hold objects over the past few days. Now he reports rapid progression of weakness in the legs. MS is an inflammatory disorder of the nervous system causing scattered, patchy demyelination of the central nervous system. What does myelin do, and what is demyelination? Well, myelin allows nerve impulses to travel quickly through the central nervous system. Demyelination occurs in response to an inflammation of the myelin nerve sheaths, resulting in separation of the myelin from the axon cylinders and an interruption of nerve transmission. In MS, the myelin sheath is damaged, leading to an inflammatory response. MS is believed to be an autoimmune condition in which the immune system, for some unknown reason, attacks the myelin surrounding the nerves. The symptoms of MS are caused by the damage to the myelin. MS is characterized by remissions and exacerbations. What happens to the myelin during each of these phases? Well, during remission, the myelin can regenerate and the transmission of the nerve impulse is restored. Symptoms decrease or disappear during this phase. The inflammation can reoccur and cause exacerbations. If it is severe, it can cause an irreversible destruction of the myelin with dense scar tissue forming sclerotic patches. The plaque permanently damages the central nervous system. The classic picture of the relapsing remitting type of MS, or RRMS, occurs in most of cases. The course of the disease may be mild or moderate, depending on the degree of disability. Symptoms develop and resolve in a few weeks to months, after which the patient returns to baseline. So isn't Dave too young to get MS? What is the etiology, and how do various forms of multiple sclerosis differ? Dave is not too young to get MS, and the rate of incidence is between the ages of 20 and 40. The etiology is unknown, but autoimmune processes and viral infections have been identified as possible causes in genetically susceptible individuals. MS is more common in cold, temperate climates. It is 12 to 15 times more common among first-degree relatives, and women are affected about twice as many times as men. Primary progressive MS involves a steady and gradual neurologic deterioration without remission of the symptoms. The patient has progressive disability with no acute attacks. Patients with this type of MS tend to be between 40 and 60 years of age at the onset of their disease. Secondary progressive MS begins with the relapsing remitting course that later becomes steadily progressive. Functioning continues to decline with no clear times of remission. Progressive relapsing MS is characterized by frequent relapses with some partial recovery, but not a return to baseline. Progressive cumulative symptoms and deterioration occur over several years. The most common is the relapsing remitting multiple sclerosis. What assessment data caused the physician to suspect possible diagnosis of MS? The urinary symptoms, which is damage to the motor and sensory control centers, ocular symptoms, that dizzy or the fuzziness he was having, and the arm numbness, tingling, and weakness due to the motor and sensory nerve tracts. There can also be symptoms associated with damage to the cerebellar region, cerebral cortex, or sacral cord lesions. Signs and symptoms of MS vary greatly from patient to patient and can vary over time in the same patient. Most common initial symptoms are sensory loss, optic neuritis, weakness, paresthesia, diplopia, ataxia, and vertigo. Diagnostic tests are often done to rule out other disorders with similar symptoms. A diagnosis will be made when the disorders have been ruled out, when the patient has 2 or more exacerbations, when there is a slow, steady progression, and when the patient has 2 or more areas of demyelination or plaque formation. Key features of MS include muscle weakness and spasticity, fatigue and tension tremors, dysmenorrhea, which is inability to direct or limit movement, numbness or tingling sensation, hyplasia, a decreased sensitivity to pain, ataxia, dysarthria, which is slurred speech, just like that, dysphagia, difficulty swallowing, diplopia, nystagmus, which is involuntary eye movement, scotomas, which are changes in peripheral vision, decreased visual and hearing acuity, tinnitus, vertigo, bowel and bladder dysfunction, alterations in sexual function such as impotence, cognitive changes such as memory loss, impaired judgment, and a decreased ability to solve problems or perform calculations. What are the 4 common diagnostic tests you can begin to teach Dave about? MRI to reveal the presence of lesions and plaques along the myelin sheaths, including their sizes and location. Evoked potential studies to document the speed of the nerve transmission. CT scan to demonstrate plaques and rule out lesions, and lumbar puncture and CSF analysis to look for elevated and specific proteins and abnormal antibody production, and also a PET scan. So Dave asks you, if this turns out to be MS, what's the treatment? Well, there's no standard therapy, and individual therapies vary widely. There are typically 2 categories of treatment for MS: treatment to arrest the disease while the process, and treatment for symptom management. In the United States, 4 FDA-approved drugs are used to modify or arrest MS disease process for the relapsing and remitting type. Interferon beta 1A, Avonox or Rebif, interferon beta 1B, Betaseron, glatiramer acetate, which is Suboxone, and methoxytrone, Noventrone. And these medications are designed to either modify the immune system, so they are immunomodulators, or shut down the immune system, so immunosuppressants, and they shut down temporarily to alter the course of the MS. Symptom management includes medications for spasticity, such as baclofen, tizanidine, diazepam, dantrolene. Sensory symptoms like amitriptyline, urinary symptoms, prazosin or oxybutynine, tremors and ataxia, clonazepam, neuropathic pain, neuropathic pain. Gabapentin is used, amitriptyline, and depression. Fluoxetine is also used. For acute and relapsing and accelerated recovery, a short dose of corticosteroids, methylprednisolone, may be given. Both non-pharmacologic, which would be physiotherapy, and pharmacologic strategies are a large part of the treatment plan, with the goal of keeping the patient as independent and functional as possible. Current Therapies for MS are designed to treat a dysfunctional immune system. A variety of medications are used to treat and control the disease, decrease specific symptoms, and attempt to slow down the progression. The National Multiple Sclerosis Society recommends early and continuous treatment of relapsing and remitting with one or more drugs. As part of your teaching plan, you want Dave to be aware of situations or factors that are known to exacerbate symptoms. It says to list 4. Well, we know that fatigue, stress, excessive exertion, overheating, which would be fever, hot weather, hot baths or showers, excessive chilling, and infections of any kind can be exacerbate symptoms. In female patients, pregnancy should be discussed with a physician to weigh the risks and benefits. Dave confides in you that he's been depressed since his parents' divorce and the onset of these symptoms. He tells you he knows his girlfriend has been faithful, but he's afraid of living alone. He's afraid if he tells her about his MS diagnosis, she will leave him. So what are you going to do with this information? Depression occurs in 25 to 55% of MS patients. You want us to thank Dave for having the courage to share something so sensitive and personal. You would suggest that you'd like to see him get help, and so he can feel better about himself, and as well as developing positive relationships. You tell Dave that you plan to ask his physician about getting a psychiatric consult for medications if those are necessary, and to help him through this phase of adjustment. Reassure Dave that the fact that he has been open with you about what is happening in his life, that he has the courage to make things better, and he has a great life ahead in spite of the diagnosis. In view of his personal history and current diagnosis, what 2 critical psychosocial issues are you going to monitor in his follow-up visits? Well, you're going to definitely look for continued signs and symptoms of depression, if he has any suicidal ideation, resources available to him, local chapters of the MS organization, support groups around town, social workers, physical therapists, psychosocial therapists, vocational rehab, financial counselors, all supportive types of services. So Dave takes advantage of his time with his psychiatric nurse specialist. He joins an MS support group, tells his girlfriend to move out, and later marries a woman from the support group. So for additional support, you could point him towards the National Multiple Sclerosis Society, and that can be found online.